Hello, my name is Jesse Milan. I'm the president and CEO at AIDS United. Thank you all for joining us as we're launching AIDS United's webinar series, Relief, Recovery, and Resilience. We'll be highlighting how communities impacted by and organizations focused on HIV are responding to the unprecedented situation of our world today. Of course, the COVID-19 epidemic is certainly unprecedented, but the HIV field is used to being adaptable. We're used to responding to rapid changes and always centering the needs of those most affected by and vulnerable to HIV. We hope to continue to highlight the practices that we're engaging in to support people living with and vulnerable to HIV throughout this webinar series. We also can't gather, not today, in any sense or in any space as HIV advocates without acknowledging the current realities of racial injustice. And we have to acknowledge the continuing health disparities of HIV and the health disparities exacerbated by COVID-19. So I ask that we stand for a moment in solidarity with all of our colleagues, our brothers and sisters working to prove that Black lives matter and who are working for racial justice. And I ask that we take a moment of silence to remember in memoriam all those who we've lost prematurely to medical racism, to state-sanctioned violence, and to the white supremacy culture. And I urge that in this moment of silence, we commit and recommit to supporting justice for all. Let's take a moment. Thank you. I'd like to introduce today our moderator, Mr. TerMeer. Tyler is the executive director of Cascade AIDS Project, Prison Health in Portland, Oregon, and he's the co-chair of AIDS United's Public Policy Council. And we're glad that he could join us to lead our discussion today about so many of the important issues we're facing in HIV services. Tyler?
Thanks so much, Jesse, and thanks to the entire team at AIDS United for their work in pulling us together for this important conversation. As I'm sure we all recognize, since the onset of COVID-19 and this public health crisis, we have been pulling together as a country and as organizations to monitor and understand the guidance from public health officials on how to best serve and protect our communities. Organizations like the one I lead here in Oregon and Southwest Washington have been faced with a real challenge of finding the balance between serving and protecting, and that balance has been hard, especially as public health and social service organizations, recognizing that the populations we serve are going to need us regardless of what is happening in the world around them, and how do we continue to provide those services to vulnerable populations in a way that still lifts up the reality of their potential past trauma around dignity of care. And so we're excited to present today from several colleagues across the country on this particular topic. Before we get started, I did just want to note that as we're here in Zoom, there is obviously the chat feature that you have seen off to the side, or you can click on the bottom of your screen to chat with us. But there is also a question and answer box that can be found at the bottom of your screen. We'll be holding questions till the end of this webinar, but feel free to enter questions, and I and the team at AU will monitor them along the way so we can address them at the end of our time together. And that there is Spanish translation available at the top of the webinar for anyone who may need it. So I am going to go ahead and turn it back over to Jesse to talk to us a bit about the COVID-19 survey that was conducted by AIDS United. Jesse?
Thank you, Tyler. And we're pulling up a slideshow for everyone to see. This slideshow is a helpful instrument to give us an overview of a survey that AIDS United conducted. And I'm going to be framing this survey as a backdrop for all the conversation discussion that you'll be hearing later today from our panelists. The survey was addressing how HIV/AIDS services for people living with and vulnerable to HIV were affected and impacted by the COVID-19 crisis. Given that only 53% of people living with HIV in this country have achieved an undetectable viral load, and that nearly 60% of the people living with HIV in the United States are over age 50, a large swath of the HIV population in our country are at great risk for serious illness because of COVID-19. So as this pandemic presents grave risk for our constituents, AIDS United launched a COVID-19 response team. And we asked that team to identify and address community needs related to COVID-19. And this survey was the first of the response team's efforts. We used the survey to address and to query all of our grantees, our Public Policy Council members, and our program and policy partners, as well as many of our capacity building recipients. All total, over 250 organizations were solicited. The high response rate shows the depth of the needs of those organizations and their willingness to have those needs documented as a result of the challenges they're facing because of COVID-19. The survey closed on May 12th, and so the data that I'm presenting is a snapshot of the needs and the responses of those organizations as of that date, which is just 30 days ago. In general, we are hearing that service providers in the field have adapted operations quickly to continue to provide services and to support people living with and affected by HIV. So here's some of the data. Approximately 140 organizations serving people living with and vulnerable to HIV responded to this survey. All of them were based in the United States, including Puerto Rico. Notably, 31% are from the Deep South. That's Tennessee, Mississippi, Alabama, Georgia, Florida, Texas, Oklahoma, Arkansas, and Louisiana. Nearly half, or 45%, are mid-sized organizations with staff in the range of 6 to 50 employees, and 28% had 5 or fewer employees. So let's look at what kind of modifications they made to their overall services. Only 19% of the organizations responding to the survey indicated that they were open and had few changes in their client-facing operations. Others are adjusting their practices by having modified hours. That's 37% of those responding. And a large number are now having staff working remotely, or they've changed their types of services from many in-person services to more remote and virtual services such as telehealth. Let's see some of the impacts on staffing particularly. The organizations varied in their modifications to staff reporting locations. The largest group, at 29% of those 140 organizations, had all of their staff working remotely. 63% of the staff of the respondents had approximately half of their staff working remotely. Interestingly, as of May 12th, 60% of those organizations responding had applied for the PPP, or the Payroll Protection Program, which was operated through the Small Business Administration. Of those 60%, 71% had received those applications. So that's as of a month ago. It may reflect on how complicated some of those application processes were, particularly for organizations of color. Layoffs and furloughs have occurred, and we need to be mindful of those. Only 23 of those 140 organizations reported that they had to furlough or lay off staff. And of those, 9 of those organizations are offering support for their furloughed or laid off staff, including unemployment benefits, assistance with food services, sustaining the health benefits of their employees who have been laid off or furloughed, and providing utility support. 9 organizations who did have to permanently lay off staff released between $1 and 9 staff members. Next. The types of services that have been impacted by COVID-19 among our responding organizations. Some of the types of these services were more impacted than others. For example, prior to COVID-19, of those 140 organizations, 11% were providing dental care services. That has now been reduced to only 5% of those organizations. That's a more than 50% reduction in the number of dental care services available to our community. Linkage to care and re-engagement services were also reduced. And psychological support services have also gone down, as have advocacy activities across the country. However, there has been an increase in the provision of services related to housing, an increase in the provision of services for food services support, and an even more significant increase in the number of organizations providing insurance and benefits assistance services, nearly a doubling or 100% increase in those providing insurance and benefits assistance. I'm certain that many of those include helping clients apply for unemployment. Next, where are we seeing an increase in client demand? 62% of the organizations responding have seen an increase in client needs for housing, and 79% indicated an increase in client demand for food services. Many organizations also indicated that clients were expressing need for rent and utility support, all which are very understandable given the increased number of under and unemployed people because of COVID-19, especially as safety net support such as the unemployment benefits and stimulus checks seem to be delayed, particularly in communities of color. A number of organizations also highlighted that their substance use services are in much higher demand, with one citing syringe exchange rates as 2 to 3 times higher than before the onset of the COVID-19 pandemic. And how are funders supporting organizations across the country? At the time that this data was collected, the respondents were almost evenly split on if they had received supplemental government support for their operations during the COVID-19 pandemic. 49% had, 51% had not yet. And a large majority of our respondents, 87% overall, indicated that some or most or all of their funders had been very flexible with their funding awards. Yet anxieties, of course, still abound across all of our organizations about how they're going to get through the rest of this fiscal year and how they will operate in 2021. So what is AIDS United's role? Next. For our part, internally, AIDS United has extended as a public health leader, we've extended our suspension of all of our in-person meetings and all of our business travel for our staff through the end of this year. We are also extending our all virtual office and its operations to the end of the year. And we're proud that AU does not anticipate doing any furloughs or layoff of our staff for the remainder of this fiscal year. To help the field, AIDS United has converted many of our project-specific grants to general operating support, and we've eased reporting parameters, and we are exploring opportunities to put additional resources into the field through AIDS United. And of course, we are creating this webinar series as a space for the field and for our communities to come together, because being a convener of the HIV community is what AIDS United wants to do. It's a program, it's a role that we hold dear. So you've heard an overview, and now we'll start hearing more about these topics as we address our panelists and all the experiences that they bring to share with all of you. So Tyler, thank you for being our moderator, and back to you.
Great, thank you so much, Jesse. And thank you to AIDS United for continuing to be a leader in helping to bring the community together and to collect vital information in real time about what's happening in the community. I can personally speak to the impact that COVID-19 has had on our organizations here in Oregon and Southwest Washington, and really made us rethink the way that we deliver services. And I'm excited to hear from others across the country and provide the space today for us to learn from one another about how we've adapted during this time. As we make our way through our presenters today, I'm going to ask, as I introduce them, that they quickly introduce themselves, so their name, their pronouns, and where they are coming from in the country or in the territories that we represent as Age United, and then move into their presentation. First up is Dwayne. Dwayne Bridges, if you could, from Thrive SS, if you want to introduce yourself and get us started, that would be great.
Hey, good afternoon, everyone. My name is Dwayne Bridges. I am the co-founder and director of operations and finance for the Thrive Support Services. And I'm from Detroit, Michigan, but I currently live in Atlanta, Georgia. So I'm coming from the South. So next slide. Okay. Well, Thrive Support Services, Thrive SS, we go by Thrive SS as well. We were founded in 2015 as a virtual support group for Black gay men living with HIV. And our mission is to achieve health equity for Black gay men living with HIV through direct support, advocacy, building collective power. We also have the largest network of Black gay men in the country, actually over 3,300 around the United States. And our work centers around self-love and HIV acceptance. Next slide. Okay, so how has COVID-19 impacted our work? Well, first of all, we started as a virtual support group. So we took it back to the basics. We're doing everything online. I'm glad to say we didn't lay off any individuals, any staff. There's 11 staff. And so right now we're all virtual. We did close our office. Sad, it's only been a year in our new building, and right now we are completely closed. Actually, recently we just opened up for just 2 hours on Thursdays for some individuals that may need to utilize the laundry facility as well as to get clothing. So I want to definitely hold that up. And I would definitely say that as individuals, I didn't say earlier, he, him, his. So I want to acknowledge that as well. We utilize creativity to assure our members don't fall into isolation and depression. So we're having virtual game nights, virtual Toastmasters, and we also are just trying to energize as much as we can right now. It's so much going on in the world. And here in Atlanta, I'm sure you heard so much throughout the streets, the march, and it's so much going on. So many people have lost their jobs. So many people are reaching out to us for housing assistance. So we're definitely resilient. However, it reminded us that in many ways that we have to fend for and prioritize our own lives as individuals living with HIV. Black individuals are dying, let's be honest, that's the truth. The lack of clear leadership and anxiety, it's crazy here. Many care facilities, one of the struggles, many care facilities we link individuals to have been slow to adapt to telehealth. So linking people to receive medical care, HIV services, it's been a struggle because we truly is a linkage and re-engagement services. So it's that's been a struggle for us, honestly. Next slide. Thank you. So as far as participation, I will say what's amazing is that since we're all virtual, we're on Zoom, we're on Teams, we're on Facebook, we're doing everything just like the way we started. We started in my home at one point when we created this nonprofit, and we did everything on social media. And so now it took us back to that moment, that grassroots moment. And so as it relates to the linkage department, it's definitely increased. We're linking people to medical services. We're still providing Lyft and Uber rides to individuals, their appointments and to get their medication, things of that nature. Food services, and that's definitely one. And I'm glad that Jesse upheld that linking people to housing and food that's been the struggle at this moment. So many people need food and housing. and appointment-only access to our on-site clothing closet, which I spoke about as well. Next slide. So the new normal. We are definitely in no rush at all to return back to the office. As individuals that are Black, HIV, within many margins of society, it is important for us to prioritize the health and well-being of our members. So we're definitely not in a rush. We don't want anyone to come face to face. I know there's social distancing. We're just not opening. Right now, the great thing is that we can be virtual. And individuals that want to get tested for COVID-19, we're definitely still linking them to services and providing that free of charge. We also have a COVID-19 fund. We raise money just to give back to the community. So individuals can come and apply and get a quick, $50 or $100 just to maintain. That may take care of someone's cell phone bill or the internet. You just never know. Something so small has definitely been meaningful in our community. We will follow definitely the scientific logic of the World Health Organization and the CDC to guide our return to the most appropriate version of the new normal past COVID. Next slide. Guess what? Your turn.
Dwayne, thank you so much for sharing the impact of COVID and what you've done to pivot during this time. I will ask one question of each presenter, but using my moderator's power here. And so my question for you is just, I think you highlight how we've really had to be creative during this time. So what is something that you think that you and your team has done during this time that will carry forward even beyond the time that we're still at these stay-at-home phase? Is there something that's occurred that you think will carry on and continue to have impact?
Honestly, our virtual happy hour, honestly, it's been amazing because with our individuals that are over the age of 50, they love it, regardless of your sipping on lemonade or just engaging. We can have those meaningful discussions virtually without even leaving our home. So we're definitely going to continue that. I think that's been actually amazing to still reach out to individuals. And I will also say that our linkage department have definitely been reaching out to all of our members in our network. And prior to that, we did it here and there, but now there has been a heightened focus of that person's position. So definitely continue to do that, to reach out more. And when we pick up our phone, just saying, how are you doing? That's important right there. How are you?
It's that connection and community. Thanks so much, Dwayne. So we're going to move on to our next presenter, and next up we're going to hear from Philomena, Quebec. And if you could start by sharing your name, pronouns, and your affiliation, and then launch straight in.
Sure. So my the name on my taxes is Philomena, Quebec. My Ojibwe name is Babiwash, and I come from the Bad River Band of Lake Superior, Chippewa. We're on the southern shore of Lake Superior in what's now northern Wisconsin. So kind of out in the middle of nowhere, dealing with this COVID-19 stuff. So in addition to, my policy work, I run a needle exchange program with some of my friends, and we do it out in, I'm still out of my house. So, we're, we haven't gotten our building yet, but maybe someday, Dwayne. So I'm just going to jump right in. If you could advance the next slide. What I like to do with these presentations is provide people with plenty of historical context and things. Our people are part of the Anishinaabe Nation, and the Anishinaabe Nation owned and controlled, passed laws, enforced laws, engaged in diplomacy and warfare in quite a large area, kind of covering the northern border of the United States, up into Canada, areas including what's now Detroit, Sault Ste. Marie, Duluth, all those different places were places that were our country. And so in the 1700s and 1800s, the United States got kind of plumb rich from stealing the labor of enslaved people and the lands of folks in the south and east of what's now the United States. And when we're looking to expand westward. And so the people had to decide whether they were going to engage in war with the United States or enter into treaties. And so our people decided to enter into treaties. The United States said, we want your land, but we'll let you stay here and you can continue your sovereign existence and we'll take care of you. And so, you know, the people said, okay, signed up these treaties. And, you know, what followed was a whole series of pretty significant human rights violations that continue on until today. If you could take it to the next slide. So, you know, there we go. The public health context that we operate in pre-COVID and continuing on with COVID is we have a number of really serious issues related to settler colonialism. So the Indian Health Service is sort of that arm of the government that is supposed to take care of health needs pursuant to the treaties and those promises that were made by the United States. But it really is significantly underfunded. And so when our people need to go to the doctor and get health care, even for small things like a blood sugar monitor, it's you know, they often don't receive it. We have a lot of police brutality and law enforcement issues within our community. And I will mention specifically that in 2018, an 8th grader from Bad River was shot by a police officer who was responding to a call on the Bad River Reservation, and Jason was killed at that time. High incarceration rates. I'm a lawyer. I do some pro bono work in the community. And I oftentimes end up going to the jail to meet with mostly Bad River tribal members, women who are dealing with issues that they need legal help on. And I mean, the things that I've seen in the jail, just make your blood crawl. You know, holding a Bad River, pregnant Bad River tribal member. And I'm she, her pronouns, for in solitary confinement for more than a month. 3 women ended up overdosing in the jail recently, and the jail does not provide any sort of treatment for opioid dependency or any kind of other drug or alcohol issues. And everybody in that jail has drug and alcohol issues. And so people are oftentimes detoxing on their own without any kind of medical intervention. And it's pretty harrowing what's going on in the law enforcement in our community. You know, not receiving appropriate medical care is an ongoing theme while incarcerated and out of incarceration. Food insecurity, we don't oftentimes have access to our traditional lands to access those traditional foods that make us strong and healthy and have kept us sovereign as a nation for thousands of years. And then, you know, the educational system doesn't meet the needs of Native communities. And, you know, for like, I'm raising 2 Native kids. We don't speak our language. Our language was taken away from us by like forced re-education camps in the 20th century that pretty much all the kids had to attend. They weren't allowed to speak their language. They were taught that they were somehow subhuman. So those kinds of things have consequences, and you know, we don't necessarily have a good education system to give our people and our kids a solid footing as Native people, as human beings. But then what's also really disturbing is the fact that most Americans don't know anything about Native America. They don't even know that we exist. So we experience racism as a forgetting, like we're oftentimes just forgotten about. And then, you know, finally, I want to just briefly touch on the fact that Native American women experience the highest rates of domestic violence and sexual violence and trafficking of women and girls is a really serious issue in our community. So all in all these kind of extra social circumstances that are happening contribute to some really big challenges for Native Americans, and put us at higher risk for HIV, hepatitis, and other kinds of really, really serious and chronic health conditions. If you could go to the next slide. So our program was formed in 2014, and we have a really specific mission to prevent HIV in our community by supporting people who use drugs. And we're a community group. We took this over. We took our program over. We do needle exchange, overdose prevention, naloxone distribution, and provide social support, nutrition support to the people that we serve. Our goal is really to go back to our traditional governance and operate our program consistent with our values as a people, develop loving relationships with people who use drugs, and get away from these punitive and judgmental relationships that we have. And so we really want to uplift their voices, celebrate their successes, and work on addressing community needs. So next slide, please. What we see with COVID-19 is it's been really challenging for us. We've had really high rates of overdoses, and we've lost 2 community members, which has been really hard. The participation in syringe services was over the top. Like I do a lot of the direct services, and I was going on 2, 3, 4, 5 calls every single day for 7 days a week for about 3 months, and then all of a sudden the line has been dead. And what I don't know if there's issues with the supply. I've also heard a lot of people are trying to quit right now. And so, we're trying to figure out how to give people support. One of the problems is we don't have a lot of providers for MAT. And so that becomes a challenge. And, like Jesse said, we're really concerned about the economic picture in rural areas. It's always bad. Homelessness is always a hard time for people. But we're really concerned about what things might be in the next couple months. So on a positive note, we're seeing a lot more interest in the larger community, and especially young people concerned about police brutality and law enforcement issues. So that's something we're pretty excited about. So we're trying to focus in on overdose prevention, doing a lot of secondary distribution of supplies, get as much supply out there with people, including masks, gloves, hand cleaners, things like that. And what we want to be doing is rolling out a community assessment tool to really figure out exactly what's going on in people's lives so that we can prepare and meet those needs. And then certainly we want to collaborate on the social justice issues that are at the root of many of our public health issues. So that I'll finish up. Thank you very much. Miigwech.
Thank you so much. Just a follow-up question. It sounds like your work in and outside of the current public health crisis is very heavy and very connected to a lot of other social issues that currently exist. How has this time impacted you as a leader, and how do you think that will influence this time will influence your work moving forward?
Wow, well, what's been really hard is trying to maintain connections with people, because I like to drive around and talk to folks on the street. And it's been really hard to do that these days. So, I just feel like really challenged as a leader at this point, and trying to figure out how to best maintain connections with people. And I was recently elected to the Ashland County Board, so I'm a county board supervisor at this point. So I'm doing a lot of troublemaking in local government, you know, and so I mean that's kind of disconnected, but I do try to shake things up and question the status quo.
So much, Philomena. We are going to transition to our next speaker, and I'd love to invite Sandra, Miranda, to introduce yourself and your pronouns and let us know what's happening in your part of the world.
I've been here in the position for only a month and a half, although I've been working with HIV for quite some years, 26 years. And I've come to work with an organization that's been serving HIV participants since 30 years. It's a well-known organization. It's small, but it's been a very important agency regarding HIV and of the most vulnerable population. So we can go to the next slide. As far as the COVID response here locally, we've been under a major lockdown since March 15. We're still under that lockdown. It has been through all the island, all government and private sector have been shut down. So we've been going through an economical crisis like everyone else. A lot of people are out of work, but luckily this major lockdown did not affect the essential services, health services. So we were able to continue providing services to the population. Next slide, please. We developed to respond to the COVID emergency, we developed an on-site prevention and clinical program protocol. So we were able, and what we're still doing is trying to protect, first of all, our patients when they come and get their services, and also our staff. We have seen a very low impact on our staff attendance to the clinic and to the prevention program, which has been good because people are trying to see some kind of normalcy in what we're doing. And I think that helps them a lot because they don't feel like they've been left out of their services. They feel a little bit more secure on seeing that these services that for them are so important are still being served. We had to adjust our service hours. There's a local curfew from 5 a.m. to 7 p.m. We used to provide services from 7 a.m. to 7 p.m. Now we're going to from 7 to 5, I'm sorry. But we're here, the whole staff is here, the whole medical staff is here, and that's been a positive thing for our population. Next. With the prevention center, and this is the center where we provide services for HIV testing and counseling. We implemented some social distancing in our very small area. We don't have a big facility, but we were able to work with our space. And we had to recreate ourselves and start using social media to impact the population and keep doing those counseling. And by doing so, we were able to reach about 4,000 individuals that we've been interacting through our social media pages. We have been able to increase our condom distribution, which is also good. We keep on giving the prevention message out and serving people not only locally in our San Juan area, but through all the island, and trying to talk to them and you know, keep them as using prevention measures as much as they can. We've also been able to impact our population by giving them appointments for HIV testing through Facebook. Again, this is something new. We like to be face-to-face all the time with our patients or with our participants, but we have been able to do that. We saw a major decrease in the visitors in the center during those those months, February, March, and April, particularly March and April. But by using Facebook, we were able to reach out to them again. Next slide. And this is a little bit of the numbers. As you see, we suffered a lot. We lost a lot of contact with our patients in April. But luckily, again, we were able to reach out to them, and we're seeing those numbers increase again little by little in May. Next slide. For the clinic, again, we also implemented some social distancing for everyone that comes in the clinic. This is for patient and visitors. Through telemedicine or telehealth, the numbers have remained steady for these participants. We've been maintaining our numbers between 160 to 297 patients per month. We've been providing COVID tests to them, and luckily no one has come out positive. And we have seen some increase on the support services for nutritional and mental health services. Next slide. These are our numbers for our clinical services. As you see, using telehealth has been a big asset at this point. We have been able to keep our patients in service, many of them in service, and knowing that they're getting their medicines and talking with their doctors and other professionals here, which is very important to them. Next slide, please. These are, I wanted to share this with you because what we're seeing a lot, and I guess it's happening to all of the other sites, is people have fear of being infected. So that's been affecting them to visiting our centers, but through, again, telehealth, we've been able to work with them. There have been some referrals for nutritional service and housing, and these are impacts of the loss, reduction in income due to the lockdown, to the local lockdown. Next slide, please. We can see here the impact on mental health services. At the same time, last year has been a huge increase, as you see, and we know that COVID has brought a lot of anxiety and uncertainty on everyone, not only HIV patients. And luckily, they've been able to have their needs attended. Next slide. So moving forward, we've been participating in the CARES Act for Ryan White Part C and D, and what we're going to do with these funds are addressing COVID tests for our HIV patients. We want to keep increasing those support services to them related to COVID. And we really want to provide our patients with their PPE kits and keep on giving them orientation on how to keep safe on all times. Next. We continue with working with our staff to keep them secure. We screen them daily. We've been training them on COVID safety measures. We've been providing them with all the PPE we can provide them, and trying to reinforce the physical barrier so they can keep on doing their services and protecting them and the patient. Next slide. So we are getting ready to loosen a little bit the lockdown. So we have to go little by little again. So we're getting ready for that face-to-face encounters by reinforcing actually the social distancing and the barriers. We have just reopened our dental clinic. We are seeing only 3 patients by day because we need to get used to how we're going to provide the services and how we're going to maintain secure and the area. And right now, through social distancing, we're getting ready for our National HIV Testing Day. Through social media, we're trying to give appointments to everyone who wants to come and give them all the prevention measures and talk a little bit about HIV face-to-face again with our population. Next. And I really would like to thank all our staff. These have been really uncertain times, not for everyone, and they have been committed. They have coming almost every day, and they keep serving our patients. And I think that's a big asset for everyone here. So thank you.
Thank you so much. I guess my follow-up question for you is, given obviously this current crisis, but on top of environmental and political crises that you have been facing there over the last couple of years as well, are there ways that others can help support across the U.S. can help support the work that you're doing or lift up the work that you're doing and help you in your efforts?
Well, actually, I think that, yes, we need to keep reaching out to other sites so we can learn from them and try to reach our population. Everyone could learn a little bit about everyone, I guess. And I think that in these troubling times, giving us support from all the small CBOs and all the small communities, we can move on forward with this situation.
Thank you so much, Sandra Miranda. We are going to move on to our next presenter, and I will kick it over to Charles King from Housing Works, who needs no introduction because he has been a long-term advocate and fighter in much of this realm. Charles.
Thank you, Kyle. And hi, everyone. Charles King, he, him pronouns. I'm the CEO of Housing Works, which I helped to found 30 years ago. We're a pretty substantial organization, over 800 employees, serve about well, more than 15,000 people every year in our programs in New York City, everything from housing to integrated healthcare, legal services, employment. We have affiliates in Puerto Rico and Haiti, whose situation I will not be including this presentation. So 1 year ago at a Housing Works senior staff retreat, I discussed the significance of achieving the ending the epidemic benchmark that I'm sure we will hit this year, in which the total number of new HIV infections will fall below the number of people with HIV who die from any cause in New York State. Assuming our continued success, every year thereafter, we will have fewer and fewer people living with HIV. So at this retreat, I laid out a vision of a future in which we would dramatically deepen and expand our housing, healthcare, and other services to people who suffer similar disparities in health as the people we serve who are living with HIV. Specifically, I named 3 overlapping groups of people: people who use drugs, people who've experienced incarceration, and people who are homeless and have chronic conditions. Already, we were serving these folk, those living with HIV and not, and while fighting HIV will continue to be at the heart of our mission until no one is living with the virus, advocacy and services for these related groups would gradually become central to what we do. Later that summer, we opened the Virginia Schubert Health Center, the first community health center in New York, dedicated solely to serving people who use drugs. And we continue to operate a reentry program for people leaving New York City corrections. Then came COVID. Next slide, please. Over 2 weeks in mid-March, we shuttered 15 retail locations. We suspended in-person adult day healthcare, and we moved everyone we possibly could to work remotely, maintaining all of our supportive housing, our syringe exchange programs, and our clinics with in-person care, and rotating staff to do intake for other services so that we could connect consumers to remote workers. We also canceled Design on a Dime, our signature fundraising event, which nets well over $1 million every year. I would be lying if I didn't say it was a scary time. All in all, we calculated a shortfall of $8 million in revenue from mid-March through the end of June, and we had only 3 payrolls in the bank. To address the financial shortfall, all of our senior staff took 3-month pay cuts, from 15% for vice president level staff to 25% for the CEO. We also furloughed and laid off a total of 200 employees, ultimately laying off a total of 75 employees, with the others being called back to work between now and the end of July. And we applied for 2 payroll protection program forgivable loans, for which we received $3.9 million. We were also fortunate to receive about $1 million in supplemental grants from existing funders, and that included HRSA, as well as a number of private foundations who are long-standing supporters of what we do. Finally, both the city and state allowed us to redeploy persons working on contracts to be a part of our COVID response. Next slide, please.
Charles,
Yes?
really quick, for our Spanish translation, could you slow down your speech just a bit?
I'm sorry. I will. Indeed. One of our biggest challenges was shifting to telehealth for about 80% of our medical and behavioral health services, as well as care coordination. This included individual and group activities, though day program clients could still come in to receive meals or receive meals delivered to their home. We had just started telehealth in March at one site as a pilot and only for PrEP. Now it was our entire future. So we deployed navigators to help clients and patients download the application and teach them how to use it. It started off slow, but by the last week in May in primary care, we were seeing 70% of the visits we had been seeing prior to the crisis, and 40% of those visits were through telehealth. Similarly, in behavioral health, we were seeing 70% of the visits that we were seeing prior, and 90% of those were through telehealth. In care coordination, we were seeing 90% of the visits, almost all telehealth. And actually in day treatment, our visits increased to 110% the visits we had been seeing prior. 100% of those telehealth as well. Am I still talking too fast? Okay.
I think we might be okay.
Okay, I'll continue. Housing Works offers a variety of prevention and treatment adherence programs. The COVID crisis and subsequent waiver of face-to-face service requirements expedited and necessitated the scale-up of remote prevention interventions that had been in process, again, incrementally over the last few years. So we saw where our plans had fallen short, but it also allowed us to develop new creative prevention interventions like after hours online group support that will likely become a part of our new service model. And I just want to flag particularly the popularity of Zoom groups for harm reduction, medication adherence, and wellness, as well as in our youth clubhouse, the popularity of Instagram Live, where we more than doubled participation by young people. Next slide, please. Our PrEP navigation program is currently serving nearly 500 patients who received their prescriptions from Housing Works. The net number increased even during the quarantine period, though only by 3 persons in April. The lower net was more due to people either suspending their use due to lower risk while in quarantine, and to people whose care was interrupted by the closure of our smallest clinic or who lost appointments during the transition to telehealth, not a decrease in the number of people requesting PrEP. The clinics have continued to provide HIV testing and PEP on site and through telehealth. Early in March, Housing Works joined with the Treatment Action Group, the Latino Commission on AIDS, BLACA, and similar organizations to form a community COVID-19 policy work group. That work group has had a significant impact here in New York, though not as much as we would like. One of our subcommittees addresses vulnerable populations, including homelessness and incarcerated persons. Next slide, please. It was through this group that we learned in March that our Department of Homeless Services policy for a shelter resident known or suspected to have COVID was to call 911, have the resident taken to the hospital with the proviso that that person could not return to the shelter without proof that they were COVID-free, essentially putting those people out on the street. This led us to write a strident letter to New York City officials, which quickly led to a call with the Department of Social Services Commissioner, who informed us that our letter had triggered authorization for him to lease as many hotels for isolation and quarantine shelters as necessary, but that he lacked operators. So we volunteered to run one. We're now running a 130-room isolation quarantine shelter for homeless people with confirmed or possible COVID-19 in collaboration with Cal and Lord. We provide 24-hour services and operate on harm reduction principles. As this has challenged our Department of Homeless Services system, we have begun to see ourselves as agents for change within a dehumanizing warehousing program. We're all in on this, and we are planning to provide healthcare and behavioral health services to a total of 4 isolation shelters. We are also in negotiation to open a stabilization hotel for homeless people living on the streets. This will be the first official harm reduction shelter in the Department of Homeless Services system, with no restrictions on residents consuming alcohol or other drugs in their private rooms. This shelter will also afford medical and behavioral health services, both on site and through telehealth. We are now also offering community COVID testing, as well as testing in the homeless shelters. Next slide, please. One last quick mention is our partnership as a part of Cut Red Tape for Heroes that has delivered over $1 million worth of PPE to some 100,000 hospital, nursing home, and home care workers, as well as people serving homeless people, and 500,000 masks to homeless people themselves. In addition, we've thrown our advocacy into the fight for Black Lives Matters and meaningful police reform here in New York City and New York State. And along with our colleagues in the COVID-19 Community Working Group, are leading the effort to have racism and over-policing declared a public health emergency in New York City with accompanying legal measures. As we begin to reopen services, we've been reminded about who pandemics hit hardest. I've been conducting an average of 2 memorial services or funerals a week since early April through May. We've also learned many of the lessons that we will use to move forward. We've deepened our commitment to transforming homeless services in New York City and are also expanding our work with people leaving incarceration as we fight to decarcerate poor people of color who suffered from years of police and criminal justice oppression. And the net is that we're ending the fiscal year financially whole. We will be adding several hundred more staff than we laid off in the next 8 weeks, and we're looking forward to continuing to build a larger and stronger organization with an expanded mission. Thanks.
Thanks so much, Charles. You know, I think throughout COVID-19, throughout this pandemic, if you're brave enough to watch the news every day, you have heard many talking and trying to compare COVID-19 and this pandemic to the early days of the HIV epidemic. And I know that there's been a lot of debate on both sides, but I guess my question really falls in the realm of long-term survivors and what we should be doing right now or keeping in mind in terms of those who were alive and survived the early HIV epidemic and are now trying to live and thrive through a new pandemic. I know here in Oregon, our Aging Well program is doing the best to make sure we're addressing isolation for those folks and keeping them connected in a new virtual environment. But what lessons might we learn and what should we keep in mind for our long-term survivors?
Well, first of all, I do want to say there are tremendous parallels in terms of how race and socioeconomic status has dictated who have suffered from the COVID pandemic, the stigma associated with having COVID, just so many different areas. And actually, one comparative for me is the rage I feel every day about how, at least here in New York, at every level of government, federal, national, state, and local, our leaders have utterly failed us. In terms of long-term survivors, actually just yesterday, I was on a 2-hour statewide forum on long-term survivors here in New York. And I think one of the toughest things for folk has been the intense level of isolation that people have experienced, not being able to see friends, not necessarily having the technical sophistication to use all of the technology that would keep people connected. Certainly what we've seen with the older folk who we serve has been a real desperation to be able to come in and be seen in person. And a lot of that is you know, quite literally, the idea of just having another human being physically touch you. For elderly people who, many of whom have stayed just completely locked in very tiny apartments for several months on end, have simply not experienced another human's touch. And I think that's something that we're going to have to address. I think we're going to see a lot of post-traumatic stress coming out of this pandemic that is piled on a lot of existing post-traumatic stress that a lot of long-term survivors have experienced.
So much, Charles, and thank you to all of our presenters today. We're going to move into our period of question and answer. As a reminder, at the bottom of your screen in Zoom, you can click on the Q&A box and submit your questions through there, and we will be happy to address them as they come up. We already have a few in the queue here, so I'll just jump straight in. The first question is there or will there be help for small organizations to meet the technological challenges of working in a virtual environment? And a similar question for how virtual environments might help clients, and will there be assistance? And this might be a Jesse question.
Great, thank you for that. And thank you to all the panelists and Tyler for your moderation. Certainly the opportunity to provide general operating support allows organizations that are experiencing more additional costs for going into a virtual world to have the support they need for managing those new processes. I know certainly at Age United, the PPP, et cetera, is helping us as we've gone virtual. So yes, additional operating support can be used and should be used for those additional costs. I am not yet aware of any one particular organization that is offering unique and specific support for going virtual. But as I said earlier, many of our funders and many of your funders are also allowing for current grants to be transformed into larger general operating support, and I think they can be used that way.
Thanks, Jesse. Our next question is going to be for you, Philomena. It looks like kind of two here. One, Philomena, are you supported by your tribe in any way? And then secondly, what does Two-Spirit support look like for HIV prevention and sexual health empowerment?
Sure. So yeah, I mean, we do receive I'm assuming this is a question about financial support, and we do receive support. The tribe was able to obtain a bunch of money for COVID response from the federal government, and so we have around $10,000 that are allocated to harm reduction efforts, and so we're working on figuring out how to how to spend those funds. And I'm very interested in figuring out ways that we can kind of mentor the people, our participants, into taking over this program so that they can have control over how it's operated and meaningful employment. Because I am really concerned about the homelessness issues, and so that's one thing that I think we're really deeply exploring. And then we also receive all kinds of other support from the tribe as well. There's sometimes people get on social media and put a picture of a syringe that they found on the street, and then there's a big long conversation about about how our program is really bad, and then there's all kinds of defenders who talk about how how it's good, and so I feel like we have quite a bit more support of the work that we've been doing in our program over the years. So our tribe is a community, and there's a money aspect of it, but there's also just us as a community working through some really tough issues. It's not it's not easy. Kind of we've had a cultural shift where a lot of people are injecting drugs now, and that's hard to take for a lot of people. So And then as far as, you know, supporting, I think there's a question about Two-Spirit and sexual health. You know, we haven't done a ton of work on that specifically, but we, you know, we really work to meet the needs of every one of our participants, and you know, figure out what they're interested in, what they need. And we, you know, we provide condoms, and you know, we haven't done so much HIV testing, but we've actually found a provider in this area who would be a good person to refer people to in case they do have a positive test. And so with some of these additional COVID funds, one thing that we might explore is doing some HIV testing. And that's not specific for, you know, for Two-Spirited people, but it's just another value added service that we'd like to provide people if they're interested. You know, I didn't talk about our values, but like our values are love, respect, humility, truth, honesty, wisdom, and did I say humility? And so those are, you know, that's kind of our operation. Those are our operational principles to work with people. And you know, one thing that's hard about our community is that, you know, with the religious, with the forceful religious re-education that our people went through, there was a lot of homophobia that was included in, you know, that whole system. It comes with homophobia and reducing the, like, devaluing women, and you know, creating like these binaries and power structures. And so you know, as a community who is working on decolonization, but, you know, like, certainly we haven't gotten there yet. Homophobia is real. It's a real issue. And especially against gay men in our community, it's really hard. And there's a lot of people who are just not out. So it's, you know, it's a sensitive thing. And it's, you know, it's more work that we have to do in order to decolonize. And you know, and so we try to be there for people as in as whatever way we can be. I've probably talked too much, sorry.
No, it's great. Thank you for the information. Our next question is going to be for Sandra, and the question is, can you further explain how you are going to implement social distancing with HIV testing, and what do you do now with testing?
I'm here. Well, we actually did, which is new for us, was start through social media, giving appointments to all who reach out to us. And we established some distancing in the counseling area. We further part the counselors. We are walking with them, with the participants, from one area to another, and trying to be as, we are individualized, but a little bit more individualized. And then giving more space between each testing procedure or contact. So we're trying to guarantee that we provide our participant with masks if they don't have, we provide them with hand sanitizers. We have put up some physical barriers to help not spread any potential COVID infection. So we're trying to adapt what we do without necessarily putting it in jeopardy what we're trying to do with the community. We're adapting, and it's been really interesting because we Puerto Ricans are like, we like to be with each other, and we like to embrace each other and touch each other. So we've been trying to change that, and it's difficult, you know. And especially when you're doing an HIV test, which is very personal, very touching. And then you have to put that space in between. So it's been an adaptation for all of us.
Right. I'm going to ask now a few questions that apply to any one of you. So feel free to chime in. One question posed to the whole group is telehealth expected to sustain beyond COVID-19? And are clients also appreciating this mode of service?
So I'll give it a shot. 3 years ago, I was pressing for changes in the regs around telehealth, and at the same time trying to get Housing Works staff to start at least experimenting with it. And after 3 years of nudging, we had finally started a pilot. Our providers are now very, very comfortable with it. Many of our consumers actually prefer it. And so I think it's always going to be now a part of the way that we deliver healthcare, behavioral health services, case management services. But it's not just telehealth. I was really surprised with how things like Zoom and Snapchat, other types of social media have actually proved to be more popular with the younger people we serve than coming in and doing something in person. So I think there's always going to be the face-to-face. That's always going to be a part of the mix. But I think we've leapt into the future. We've been kind of forced into it.
Yeah.
Can I add to that? Yeah, it's going to be interesting for us because I think that at the beginning of all this, we were thinking that's not going to happen. Telehealth for us is not an option. And what we're seeing is that people actually like it. We'll need to see after the lockdown ends and how people are going to respond, that we're going to go back to our old ways. I suspect that younger participants are going to try to use this mechanism, but maybe older participants that are used to getting face-to-face contact with their provider and talking and having that physical contact will want to come back to the traditional medicine. But it's something that we'll need to see. It's going to be very interesting, and we're going to learn a lot about the system now.
Another question for the group is, what are ways that we can be engaging our local Ryan White planning councils to do the necessary work to support the high need for housing, food, and mental health services within HIV communities?
Can I jump in again?
Yeah, go for it.
We're going to need to be more engaged, definitely, because after what we're seeing, I'm suspecting we're going to have a lot of other needs show up. And all those support services that our participants are going to come up with, nutritional needs, I'm sure we're going to have a lot of those, particularly because when you have low income, you don't necessarily have a good nutrition that maybe stays back. And we're going to need to reinforce that. Then we're going to have mental services programs that we're going to need to reinforce. I'm sure there's going to be a lot of anxiety coming up in the future. So all those support services, we're going to need to engage all those Ryan White programs into it to help our patients go through.
And I would like to add, if that's okay.
Right.
I definitely think it's important to be connected to the community. So if you're planning council, hopefully there's community a part of that planning council, and I think it's time to really listen to them. We know resources, we're connected. Allow the community to provide those resources and linkages. We definitely have to work together with our community partners, and I just want to uphold that. So often we feel like we have to have the answers at a planning body. No, allow the community to come in and talk about what they're providing. And we sometimes have to take it back, the old school, ways to do things. So often we have this structure, this agenda. Now it's time to set some time aside to provide true community input.
Speaking of community, one of our participants is asking if anyone has found safe yet compelling ways to engage volunteers during this time.
We have been using volunteers mainly for our PPE distribution program. There's been a lot of packing of kits. In fact, we could even, we've been packing 14 surgical masks in a plastic baggie for each homeless person, a 2-week supply. And we've been able to drop off 1,000 masks along with baggies to an elderly volunteer's home, and they pack them and we pick them up. But we've also had younger volunteers eager to get out on the street and be part of physical distribution. As we start reopening, we're looking for other ways to incorporate volunteers. And of course, we've always incorporated volunteers in our advocacy and have continued to do that, though that's been through remote activity.
And for us, definitely allowing our members, which are volunteers, to create things, create discussion groups, lead those discussion groups. Absolutely, that's been very important, and it's been working for us. So right now we can plan an event, but we don't know when we can have the event. So definitely, it's all about community engagement with Thrive.
I want to jump in and say that we have, while we've had an increased demand for food and nutritional support, and we've been supplying meals to everyone in our supportive housing so they didn't have to venture out, which we wouldn't normally be doing. We've been especially blessed by restaurants and other businesses that have decided that they would just create meals for us and donating them by the hundreds, which has dramatically reduced what we've had to spend to purchase meals.
One of our participants has asked, well, they state that they appreciate the acknowledgement of long-term survivors and older adults, and that they may have limited proficiency with technology, Zoom, texting, et cetera. But wanting to know, given that some older adults or long-term survivors might be very proficient in technology, how do we avoid dividing our participants into haves and haves-nots, so to speak?
So one of the things that we did was, and this isn't anything to do with older, but we had a number of participants who did not have smartphones. And so one of the things that we did was we just went out and bought them and have been giving them away. We've given away probably 500 smartphones, and we're paying the monthly service fee for them, so that those folk who tended to be folk at considerable risk could use the technology. And again, I mentioned this in my presentation, having navigators actually sit down with people, help them download applications that they might use, whether it's the telehealth app or Zoom, and then showing them how to use it several times over if we need to, until they get comfortable using it. And I think that's very important, particularly for older folk.
And if I might add, I don't have an answer for that, but I think that more than older survivors, we have to see at those other participants that really don't have access to a computer or a smart telephone. Not everyone has, and it doesn't have to do with age. It's going to be has to do with homelessness and other vulnerabilities. So that's a question of looking forward and seeing how we can reach them and not leave them behind with all this technology issues. And we can't forget the other vulnerable persons. We have to keep looking onto them and trying to give them the same access to service as the rest of the population. So it's not only a matter of proficiency with the computers and the technologies, there are other issues at hand that we need to keep looking on.
A couple of internal questions, not about the work we're doing externally, but how we're functioning on the day-to-day internally. So one is, did any of you have to make policy changes in your employee handbooks? And for those organizations that have not gone completely remote, have you been able to pay your staff hazard pay?
We have a integrated committee, various levels of the staff of the organization and various representatives of our boards that went through, have spent weeks going through policies to update them for where New York is just now in phase one. New York City is in phase one recovery, but phase one, phase two, phase three, phase four, all of our policies and procedures we've gone through and scrubbed to meet the new circumstances. In terms of hazard pay, the only place where we have been able to do that, we were able to write hazard pay into our contract for operating the COVID shelter, where we knew that every resident would likely have COVID. And there we pay all of our employees a 20% premium over what they would be making in the same job in other parts of Housing Works.
Thanks, Charles. Well, you know, as it goes in any good webinar, we have more questions than we're going to have time to answer today. But we will make sure that for those questions that weren't answered, that we're able to loop back and provide a response from our participants or from staff at AU. As we close out today, I thought perhaps we could answer one final question that came through, and maybe I'll go down the line through each of you. The question is, in light of recent troubling events that have been happening across the country, what would be the best piece of realistic yet inspirational advice that you live by every single day as leaders that would boost the morale and maintain the hope of community members who want to do their best in helping others who are hurting at this time? Maybe we can start with you, Dwayne.
That's a good one. I definitely would say we lead with love. So often people don't feel valued. And as an individual living with HIV, you know, experience X, Y, and Z, you know, so sometimes we just want to hear that, you know, I'm here, I see you, I understand what you've been through, and lead with love. We care. We started Thrive as 3 individuals living with HIV, wanting to make a difference. So continue to lead with love, and don't be afraid to speak up and reach out. I'm just thankful that we have this. I didn't even talk about this. We've been doing more ads on social media for linkage to care. And I think it also, you know, played a role. And some people, they're at home, so they're looking at all these ads. Hey, connect to care again. Are you out of meds? And when we connect with them, just letting them know, hey, we also have a support network. This is what we do. We lead with love, and we're one unified body, and you are worthy. So I definitely would say continue to encourage people that you are enough, you're valuable, and I see you.
Thanks, Dwayne. How about you, Philomena?
Wasn't quite ready. Okay, I would just say, I don't know, maybe do one little more thing. You know, it's like you, I'm kind of a busy bee, and I have my hands in a lot of different pots, you know, but it's like, be brave and just speak out and do, you know, do one more thing, like just get out of your shell a little bit. I know, like, you know, with this whole thing, I've been really challenged with my mental health, and you know, trying to manage all the challenges that it is to be sort of isolated and all that. But you know, if you can do like one little thing for somebody else to you know, to make their day better, to make our world better, write a letter to the editor, or you know, reach out to somebody who's vulnerable and see what's going on in their life, or you know, write up a mad email to the mayor or the police department or whatever. You know, I mean, I think all those things are really valuable, and I'm really heartened to see some of the stuff that's going on in Minneapolis with the community really taking over public safety and coming together, feeding folks. Those are, I mean, we're human beings, and even though we live in this world where capitalism has really taken over a lot of our social relations, we can, you know, we can do things. Even doing small things is incredibly meaningful, and you know, it can change the world. So that's what I'd say.
Thanks so much. How about you, Sandra?
You know, just let them know you care as much as you can. You know, be sensible to them. Let them know that you know their needs with this COVID emergency. I think many of us have felt so alone and without direction, and having HIV and being vulnerable, just be there for them and provide for them, and let them know that they're not alone. They're not alone. You're with them, and you're going to help them through the process as much as any other person that's in a better place in life than maybe many of them are. Just care for them and do your best to help them.
Charles?
Yeah, I first of all, I totally endorse Dwayne's lead with love. I believe that, and try very hard to live by that. But there's one other thing that I learned in the late 80s in the AIDS epidemic, and that is to allow crisis to bring about transformation, whether it's personal, organizational, or societal. And I tried to reflect in my presentation how this crisis has propelled Housing Works into the future in a lot of different ways. Here in New York, many of us have been fighting for years to get rid of old civil rights, can't believe it's called civil rights legislation, that allowed police and corrections officers to keep their complaints about their performance secret. And we saw that repealed by the legislature just yesterday. We saw chokeholds made illegal in New York State. So, you know, things that past similar crises didn't change, all of a sudden we're seeing change happen, and I believe that's potentially transformative, and we should look for moments of transformation and help make them about.
Relief, recovery, and resilience. We're so happy that Age United put this beginning of this webinar series together, and I am going to turn it back to Jesse to see if he has anything to add as we close out the call about his thoughts of inspiration for leaders during this time.
Thank you, Tyler, and thank you to all of our panelists and to everyone who tuned into this webinar. This is the first of a series, and we will have more as we're all working to be resilient in this combined world of COVID, HIV, and the economy. And I think finally, Tyler, we, the HIV movement, plus our allies in social justice and racial justice, we are the majority. Let's act like it. And that includes get out and vote. Raise your voices and get out the vote.
Thanks so much, Jesse. And thank you all for tuning in today. Be safe, be bold, be well, and we'll see you on the next webinar. Bye, everyone.
Bye.
Thank you, Tyler.
Bye, thank you.